Thanks so much to the moderators, Dr. Grusel and Dr. Hawkins, for the invitation. Thanks for everyone being here. I have no disclosures. So we'll be discussing the epidemiology of anastomotic leaks after colorectal surgery. We'll discuss who needs an operation and when, who does not, and what to do about an asymptomatic leak, non-operative and operative management. So colorectal anastomotic leaks are very feared and dreadful complications after colorectal surgery. There was a systematic review performed in 2015 that showed anastomotic leaks can occur anywhere from 1 to 19%. These rates do vary by the type of anastomosis. Enteroenteric has the lowest, and colorectal or coloanal has the highest chance of leak, and the rest of the anastomoses are somewhere in between. Leaks lead to significant morbidity, mortality, and prolonged hospital stays. They increase hospital costs and use of resources. And also there's been several studies that have shown that there are worse oncologic outcomes if a patient that undergoes colorectal surgery for colorectal cancer has a leak. So in a study that reviewed 1,700 patients, they found a leak rate of 5% for colorectal cancer surgery. And after controlling for patient factors, surgical factors, and cancer or tumor-specific factors, they found that leak was an independent negative predictor of overall and cancer-specific survival. So when we talk about how to manage anastomotic leaks, it should be guided by clinical course. So this includes consideration of both the acute symptoms and then also long-term function, and also plans for the patients, talking about adjuvant chemotherapy down the line, expected bowel function and quality of life. The International Study Group of Rectal Cancer did come out with a staging system, and they grouped anastomotic leaks by grade A, B, and C. A would be those that are usually asymptomatic, may be found on CT scan, where they have the anastomosis that's associated with the anastomotic fluid collection, or maybe some succus that ends up in a drain you left in the pelvis, or an EC fistula, but the patient really has minimal symptoms. Grade B is when the patient does have some symptoms, and it usually requires some sort of intervention, but not necessarily a laparotomy. And grade C is usually when the patient is quite sick, they require a reoperation, and the goal is really to control the sepsis and manage the patient's sepsis and control their basically leakage of feces into the abdomen. So when do we operate? So this is actually the easier question. So we operate when the patient's unstable. We operate when the patient has peritonitis, if they're having systemic organ failure, or if there's a combination of clinical signs that include an increasing white blood cell count, acidosis, severe abdominal pain, worsening kidney function, or air, fluid, or contrast that's seen to be extravasated on the CT scan. What about when not to operate? So when those signs are present, then that's when we would consider non-operative management. So usually IV antibiotics is the first line. We always start those, and then we figure out some sort of drainage procedure. So drainage usually can be sometimes is with percutaneous drainage, and this can be either transabdominal or transgluteal. But what needs to happen for allowing for some sort of percutaneous drainage is that you need to have a presence of a safe window radiographically. Your hospital should have some experienced interventional radiologists to perform the drainage procedure. The fluid collection should be homogeneous and usually filled with fluid and or air. And then you need a large enough abscess. So usually abscesses that are 3 centimeters or greater should be amenable to drainage, when much smaller ones may just respond to IV antibiotics. So there's a bunch of endoscopic options that have been reported in the literature. There's not a lot of big studies that look at colorectal anastomotic management, but they're included in studies that look at colonic perforations and other types of fistulas as well. So there's a whole list of these. So one option is through the scope clips, and these are clips that can be used with standard colonoscopy, colonoscopy scopes. They usually can be used when the defect's less than 2 centimeters, usually about 1 centimeter. If the defect's about 1 centimeter, or larger than 1 centimeter, you can combine techniques, including an endo loop and a through the scope clip. If the tissue is inflamed or indurated, it may be more challenging. Sometimes gentle suction would be able to evert the edges of the tissue, approximate the tissue better, and then allow easy placement of the clips. There was a series that looked at 7,000 colonoscopies, and that out of 27 patients that had a perforation and a defect that was repaired endoscopically, 25 were managed successfully with just through the scope clips. Over the scope clip, or what we consider called the bear claw, can be used, and this is actually used for full thickness closure of defects. It can be up to 2 to 3 centimeters in size. They can be used for long-lasting leaks or fistulas, and sometimes even with surrounding inflamed and indurated tissue. Because of the greater compressive force and tissue capture, these actually can work better, but unfortunately they do require some additional equipment and expertise. So there's all sorts of equipment that you'll need, including a hand wheel that's attached to the working channel, an applicator cap, and that's where you place the clip. You need to position appropriately for the clip placement. Hopefully the entire defect can be suctioned into the cap and then the clip applied, and this does predict success. Turning the wheel will deploy the clip, and you can use this, additional clips can be applied. Endoscopic suturing is another option for non-operative management. There's an overstitch endoscopic suturing system. This can be more technically challenging. It can also close larger defects. It requires a double lumen scope, although I think there is a single lumen system that's available. Components include the end cap, a needle driver, and an anchor exchange catheter. Tissue approximation and suture placement may be facilitated by a grasping forceps or a helix device. This does allow interrupted or continuous suture placement without removal of the device, and you can use both absorbable or non-absorbable sutures. A small study that was performed at a single institution in 2016 looked at 21 perforations, which were all closed endoscopically. 5 were done with clips and 16 were with endosuturing. The patients that had endosuturing had less surgery. They were more successfully closed, more cost-effective than compared to either the clips or surgery. However, the limitations of the study, it was a very small study, single institutional study, and they were only using the through the scope clips and not the bear claw, so this may have been a little bit biased. Covered esophageal stents have been actually kind of looked at more recently and becoming a bit popular. There's been a handful of studies that have reviewed these stents to help heal anastomotic leaks. One group with Kim and authors showed a technical success rate of 100% and clinical success of 80% with these stents. 1 out of 5 patients had a clinical failure, but the stent was only placed for 20 days, and it may just not have been long enough. 60% of patients did have rectal pain, and 40% did have migration of the stent. Another group reported on this using esophageal stents for colorectal and anastomotic leaks. Pain occurred in over 60% of patients if that placement was an anastomosis that was less than 5 centimeters from the anal verge. So lower anastomotic leaks may be more difficult to manage with these stents. 8 patients did have the covered esophageal stent placed. 3 had a leak, and all 3 of these leaks had healed after the stent was removed. These stents were noted to be left in place for a mean 45 days during the procedure. And finally, another endoscopic treatment for anastomotic leaks is endosponge, or the endoluminal negative pressure therapy. This was first described in 2008. It's effective for closing extraperitoneal anastomotic leaks. Hayden and his group reported on successful treatment of 29 out of 34 anastomotic leaks. Leaving the sponge in took about 34 days with an average of 11 exchanges. Another group reported that they healed 14 anastomotic leaks. It took about 40 days. They did find a greater success rate in patients undergoing treatment of the anastomotic leak early, and then also those that did not receive any pelvic radiation. Despite the approval from the FDA, Braun Medical no longer manufactures the endosponge in the United States. Oops, wrong way. Here you can see how the endosponge is utilized. The introducer sleeve is fitted over the endoscope. It's placed through the anastomotic defect into the cavity. It's positioned, is verified with the scope, and then sponge exchange happens every 2 to 3 days, downsizing the cavity, downsizing it as the cavity decreases. Again, this showed a good success rate, and then you just remove the sponge once the cavity is less than 1 centimeter in size. You can also use additional adjuncts to this treatment, including fibrin glue. So now what happens if you actually need to consider surgery? So when we talk about operative management of leaks, if there's no improvement after non-operative management or the patient does develop peritonitis or sepsis, then surgery must be considered. So the goal would be source control with washout and fecal diversion. The type of operation does depend on the health of the tissues and the size of the defect. Minimally invasive surgery can be performed as the take-back. A retrospective analysis showed laparoscopic peritoneal lavage and ileostomy creation has a lower morbidity, sometimes in lower surgery, so it's a reasonable option. But safe and efficient management of these patients should be the priority regardless of the approach. So this was a chart that maybe I can only see that was published in the Clinics of Colon and Rectal Surgery in 2019 by Dr. Soar, and she goes through all of the different caveats of how we manage these leaks. So for example, if you have a low-lying diverted anastomotic leak in a stable patient, examine under anesthesia with proctostomy to place a drain through that defect into the fluid collection would be the treatment of choice. It's especially effective if the defects are small and there's an associated draining sinus cavity only. Transanal drainage allows for radiographic surveillance of that cavity because you can put contrast through that drain. The drain can be removed when the cavity has decreased to that size of the drain. And then successful resolution may not, unfortunately, successful resolution, even if it does work, may not remove the risk of long-term complications, including bowel dysfunction and stricture formation. However, if the patient is unstable or there's an uncontrolled leak, the patient needs exploration. The type of intervention does depend on the stability of the patient and the intraoperative findings. Again, if you performed a minimally invasive operation, whether laparoscopic or robotic first, you can attempt this for the second look. So at the time of operation, if there is a large phlegmon or the bowel is matted, avoid dissection, just wash the patient out, place drains, and perform proximal diversion. If it is safe to actually isolate the anastomosis, assess the defect. If the tissues are healthy and the defect is less than 1 centimeter, you can primarily repair that patient and then also divert them. One tip is always to keep your patients in lithotomy. All of my patients for every case are in lithotomy, but if you happen to not usually do that, except for your lower anastomoses, I would recommend this. This allows you to access the anus and place a scope to then assess, to look for air bubbles. If you can't really see the defect, identify the anastomosis and also assess the health of the tissues. If the defect is large and the tissues are not healthy, then you need to resect that anastomosis and create an end colostomy. And finally, if the defect is large, but the tissues are healthy and the patient is stable, you can redo the anastomosis at the time of the take-back, but also would consider a proximal diversion at that time. Thank you.